Afternoon, everyone who's rejoining us. We just finished all the student poster session with all their presentations. I know my session was very exciting. I learned a lot, and I congratulate all the students who presented, put time into the effort of preparing and presenting their work. And congratulations to those who are moving on to graduation in just a very short period of time. It's now my distinct honor and true pleasure to introduce Dr. Manal El-Sayed, who's professor of pediatrics at Ain Shams University. She's a clinical director of the National HCV Pediatric Treatment Program and director of clinical research unit and co-supervisor of the Viral Hepatitis Treatment Center at Ain Shams University. Manal has worked in pediatric hematology and oncology teams at Ain Shams University, the National Cancer Institute, and the Children's Cancer Hospital since 1990. And as you can see, she will be speaking about the impact of hepatitis research on the public health policies to eliminate viral hepatitis in Egypt. But before I give her the podium, I just want to set the background for why we chose this. As most of you know, the theme of this Global Health Day is innovation and impact. And where can individuals truly make an impact on a particular disease or disability globally? And when we looked at viral hepatitis, which is now one of the leading causes of morbidity and mortality in the world, one looks first at Egypt. Egypt right now has about an estimated 8 to 10 million people who suffer from viral hepatitis in Egypt. Hepatitis A, hepatitis E are major causes of viral hepatitis. And as many as 50% of the Egyptian population may have already been exposed to hepatitis A by the age of 15. Similarly, many Egyptian population test positive for HEV antibodies in the first decade of their life. HEV, as well as the others, can cause self-limiting hepatitis, cause cases of fulminant hepatitis and liver failure. And in addition to those, we have hepatitis B and hepatitis C, as well as hepatitis D, still as major causes of chronic hepatitis, liver cirrhosis, liver cancer, hepatocellular carcinoma. Globally, why Egypt? Globally, Egypt has the highest age standardized death rate due to cirrhosis from 1990 to 2017. Although that is changing, and it's why we've asked Manal to talk to us. The prevalence of HBV, which is anywhere from 1.3 to 1.5%, has declined after the national infantile immunization programs that they put in place. We're primarily going to talk about hepatitis C in this talk. And globally, an estimated 58 million people suffer from chronic hepatitis C virus infection, with about 1.5 million new infections occurring each year. There is, and according to WHO, an estimated 3.2 million adolescents and children that develop chronic hepatitis C infection. Once again, Egypt appears to be the country with the highest HCV prevalence worldwide. 4.5 to 6.7% of individuals between the ages of 1 and 59 have a positive serologic result for hepatitis C antibody. That works out to about 4 million people, and 4% have been found to have an active infection. So with the current effort to battle HCV, now Egypt appears to be the success story on how to tackle such a high burden of an endemic disease through a comprehensive elimination program. Egypt is now focusing on continued healthcare support, awareness, education, and as we heard just before you joined us, really advocacy. The type of advocacy for hepatitis treatment, recognition, treatment, and care that has occurred in Africa should be occurring in the US and many other countries. With that as a background, a little bit about our keynote speaker. Manal is a founding member of the Egyptian National Committee for the Control of Viral Hepatitis, charged with planning and implementing the national program for prevention and management of viral hepatitis since 2006. She's contributed to the establishment of a national network of 55 specialized liver centers that provided interferon therapy to 350,000 HCV-infected patients. Since 2014, the National Committee introduced the new directing acting antiviral agents for HCV, and more than 3 million people in Egypt have been treated. Manal collaborated on the development of this National Action Plan for Prevention and Control of Viral Hepatitis. It was published in October of 2014 with representatives from the WHO, the CDC in the US, the Pasteur Institute, and other national stakeholders. In addition to co-supervising the nationwide mass screening program for adults and children, she has reached out, and this program has reached out to more than 56 million people. Truly a phenomenal undertaking. Manal is an active board member and Secretary General of the Egyptian Liver Care Society. It's an NGO that offers financial assistance to patients receiving treatment for hepatitis or even liver transplants. She's authored numerous journal articles on hepatitis and liver disease, participated in WHO's HBV, HCV, and diagnostic guidelines, and she's been vice chair at WHO's Technical Advisory Group for the Prevention and Control of Viral Hepatitis in Egypt. She's also a board member of the European Study of Liver Disease, International Liver Foundation, since January of 2018. She serves on the Oversight Committee to End Hepatitis by 2030 initiative, which was initiated back in 2019. Without further ado, I thank Manal for joining us today on Global Health Day, and I turn over the podium, and I hope everyone welcomes her today. Thank you, Manal, once again for accepting our invitation to join us. It's all yours.
Thank you so much for this very kind introduction and for inviting me today. That's really an honor and to share our experience. I'm going to start with my disclosure, but I'm going to say just a few words about how I started, I think because there are lots of students attending. So that was actually my PhD thesis, which is exactly, we call it doctorate thesis because it has both a thesis, I have to defend my dissertation, and then afterwards we have an exam of 2 parts to get the degree. So hepatitis C was discovered late in 1989, and I started working on my thesis 1990. It was the first internationally or globally recognized study on hepatitis C in children, and it was in collaboration with the Naval American Medical Research Unit in Cairo. They were the only labs doing the hepatitis C tests at this time point, and we tested children who were multi-transfused, and we were surprised to find 90% of them at that time who had antibodies against hepatitis C. Later on, I had so many research studies and projects and collaborations and eventually was nominated in 2006 as a founding member for the Egyptian National Committee for Viral Hepatitis. So the key facts from my presentation here, I think that was in the introduction very clear that viral hepatitis still remains a major public health problem, and elimination is definitely feasible. We do have the diagnostics, we do have the medications, and we have the tools of implementation that can prevent liver cancer and save lives, but we have to act right now. We cannot wait, because every 30 seconds, someone loses their life for either hepatitis B or C. So we cannot wait anymore. And there are so many lessons learned and opportunities and guidance to scale up towards 2030 elimination targets, and alignment of health system and services, innovations, collaborations, and financing mechanisms can promote hepatitis elimination globally. And if we look at the status, the current status of hepatitis globally, we'll find that for the Global Progress Report on HIV, viral hepatitis, and STDs in 2021 by WHO, we have an estimated 3 million new infections in 2019, 1.1 million deaths in 2019, and a little bit slightly less than 1% hepatitis B prevalence in under fives. But Africa and sub-Saharan Africa in particular still have a 2.5% in the under fives. This means that the vaccination programs are very weak, and they're still not vaccinating at birth, and they are still not preventing mother-to-child transmission of hepatitis. So looking at the cumulative numbers of patients receiving hepatitis C treatment in 12 selected countries by WHO between 2014 and 2018, you'll find that Egypt tops all countries, and the majority of patients until 2018, almost 60% of those treated globally, were treated in Egypt. Of course, the key enablers for accelerating elimination are availability of simplified norms and standards, quality assured product options, affordability in different country contexts, equity in access, and I'm going to show you some examples of equity for all populations in need, efficiency in delivery, and indeed the government commitment and the funding. I like this slide, and I'm quoting this slide from the dear friend Harvey Alter, who was the Nobel laureate for discovery of hepatitis C. And this is always the first slide in his presentations. Viral elimination, one country is worth 1,000 speeches. And he always refers to Egypt as the hero country that managed to eliminate hepatitis C. So this is the Egyptian HCV elimination program development through the years. We started as a national committee in 2006, and we established several liver centers and a data networking system where patients were registered, and we managed to treat 350,000 with, at that time, the only available treatment for hepatitis C, pegylated interferon ribavirin. Unfortunately, of course, it was an injectable, has to be given on weekly basis, had severe side effects, and only a response of 40%. With the discovery of the new direct-acting antivirals and the promise for complete cure of hepatitis C in the majority of patients, Egypt managed to negotiate the prices and introduce the brand direct-acting antivirals. And within a couple of years, we managed to introduce also the generic drugs with 1/1000th of the price globally. And at the same time, we developed a new action plan that was published in the same date when we launched the direct-acting antivirals in 2014. And then all those who knew that they were infected, they were out, we were out of registrations, no more registered patients. The program was losing momentum, so we started some active screening at a limited scale for high-risk populations. And then we managed to detect only 60,000 cases. And then this was the cherry on top of the cake with the presidential initiative to screen the whole population, those above 12 years of age in 2018. And I'm going to show you the hierarchy of our program and how we moved from one place to the other. If we look at where we were exactly in 2008, we had integrated the hepatitis C testing within our demographic health survey, and we learned that 15% of the population had antibodies against hepatitis C and 10% were infected. And from there, we moved with our program. And when we started testing again, and in 2015, with the programmatic approach, we were down to 7% infected and 10% with antibodies, and an estimated number of 5.5 million who had the active viremia. And if we look at this map, we'll find that Egypt here had maybe a higher prevalence than other countries, but the burden of disease, of course, in China and in Pakistan was higher because of the population number. And as many patients with HCV in Egypt at that time were there as much as in 38 countries in Europe, excluding Russia and Turkey, as you can see from this map. But this is more interesting because Egypt has limited resources, and these are World Bank data, some of them for 2019 and others for 2021. And the per capita GDP is 3,698. Total health expenditure as percent of GDP is 4.7%. Current health expenditure per capita is only $149 US, and domestic government health expenditure per capita percent of current health expenditure $161, and the domestic government health expenditure percent is 27.7%. Let's compare this with the data for the US, for example. A huge difference in the per capita GDP, huge difference in the total expenditure percent of GDP from 4% to 16.7%. A current health expenditure, huge difference. It's phenomenal. And among other numbers, as you can see here, the difference between Egypt as a resource limited setting and the USA. However, we managed to have elimination targets in place and an elimination plan. Our target was mainly a less than 2% seroprevalence by 2025 and less than 1% seroprevalence near total elimination by 2030. And in this modeling study, we learned that to reach our elimination targets, we needed to increase the annual number of treated patients to almost 300,000 per year. And of course, that was possible with the direct acting antivirals and the number of liver centers that we had at that time, and we increased the number to accessibility to within 50 kilometers from every single patient. We started only with 26 specialized centers, but you will see at the end of the campaign, we had 125 specialized liver centers. We anticipated, with the starting use of the direct acting antivirals, 300,000 interferon ineligible patients who registered initially but were not eligible for interferon, 150,000 interferon failures, and around 500,000 living with the diagnosis, but they did not start the treatment yet. So we anticipated around 1 million patients to start treatment in 2014. But despite that, we had an action plan that was published in collaboration with Pasteur's Institute in 2008 that had most of the elements of elimination of viral hepatitis, but missing a few. We started to work in 2011 in collaboration with WHO and US CDC on a new plan. But this plan had all the elements from ensuring advocacy and governance, and had infection control, blood safety, also the education, communication, surveillance and vaccination, as well as screening, care and treatment. And it also had within this action plan the awareness part, the blood safety. We had a special group for the blood safety, and now, and thankfully, in the last several years, we started to implement a huge national program for blood safety that's now very strict. And we introduced also the safety engineered devices in the majority of hospitals. And now we have 3 big factories in Egypt who had transferred know-how for the safety engineered devices, the auto-disabled needles, and now they're manufacturing millions of syringes every year, which are used in hospitals instead of the regular syringes, because we had a problem with injection safety, not injection safety in the injecting drug users like in the US and other countries, but also within hospital facilities and within the healthcare facilities. Surveillance, we've strengthened our surveillance system, and for vaccination, we introduced for the first time the birth dose of hepatitis B since 2016. We had been giving the hepatitis B vaccination since 1992 at 2, 4, and 6 months, but we also introduced the birth dose of hepatitis B. And we anticipated treating those 300,000 annually, but also we had the governance part with all and the multiple stakeholders engagement. But of course, we are still of limited resources, but we have affordable drugs. First of all, we negotiated access price for 12 weeks treatment with the brand sofosbuvir that was initially given either with interferon or ribavirin at $900. At that time, the cost for the full course instead of $900 was $94,000 in the US. And then we negotiated other drugs as they came through, including the clatesvir, and eventually in 2016, we had our generics, and now the combination for the full course treatment is around $45, which is almost around 1/1000 of the global price of the full treatment or full cure package. After the devaluation of our pound, of course, the price is even less and less and less. And now we have one of the lowest prices in the world for the drugs for hepatitis C. Just a look at the national program and what we did in 2014, also with the introduction of the direct acting antivirals, we started the registration and online appointment reservation system where we have all the data of patients who register from national ID to name, the mother's first name, to make sure this is the right person. We had the database for the national IDs integrated within our operating system to be able to know the residence of every person and to direct him to the right center that is close to his residence once he registers on the system and gets an appointment in a center that's close to his place. In the first week of the registration system, we had almost 1 million people who registered on the system. So that was really amazing. And our system, thank God, didn't crash. And then eventually we had more people registering and being referred to their centers. Initially, the waiting time was 2 months, but eventually the waiting time to start your treatment would be only 1 week. In 2017, we published our national treatment program of hepatitis C as a model of care for other countries. At that time, we had 65 centers affiliated to Ministry of Health, and under Ministry of Health also is the health insurance organization with 80 other centers, and they were geographically within 50 kilometers of patients' locations. More than 1.5 million were evaluated, and more than 1.4 million received treatment by that time. And we published even more about how to plan and prioritize direct acting antivirals, lessons learned. Initially, in the first 6 months, we were prioritizing those with advanced liver disease, and then eventually everybody was allowed to be treated. By 2017, we started to run out of registrations, and this meant that we just scratched the tip of the iceberg. We just diagnosed and treated those who knew that they had hepatitis C, those who are interferon non-responders, those who are interferon ineligible. So we had to go for active screening. And by that time, the awareness was fantastic in the community. I'm going to show you the media played a huge role in the awareness once we started our program since 2006. But more and more when we started DAAs, drugs that were very easy to take, oral tablets for 12 weeks only, mostly single tablet a day or 2 tablets at most, and the cure rate of more than 98%. So that was really amazing, and that prompted a lot of people to get tested. So we started with the high-risk populations, blood donors, visa applicants, inpatients in hospitals, the healthcare providers, prisoners, and then eventually we went to those applying for national IDs, driver's license, if they wanted. Of course, it was totally sort of volunteer screening. Enrollment in universities, particularly medical schools and nursing schools, draft into compulsory military service for all males. They had to be tested before they were recruited in the military, because we have an obligatory recruitment for all males between ages 18 and 25. And then we have marginalized, unless they have they are studying, it is being postponed. Marginalized populations less than 18 or more, over 60, were still among the high-risk groups who were not tested here. In these campaigns with mobile units and screening sites, we managed to screen almost 6.4 million between 2017 and September 2018. And this shows you how the program was running out of registrations and momentum. And when we, by 2017, treated all those living with the diagnosis, and we treated almost 2 to 3 million since we started our program. By that time, with undiagnosed HCV infection, we knew that they were still under the iceberg. They did not know of their status. We managed through those campaigns, small campaigns, we screened 6.4 million, but we managed to detect 60,000 identified Hep C cases from those campaigns. And then it was not very effective. One of the problems with it, that we were testing through ELISA-based tests, and that needed specialized trained or specialized training in venipuncture. And of course, not everybody could tolerate a blood sample being taken in a mobile unit or in some of the sites or facilities. And the reporting of test results took a day or two. And despite the fact that mobile units visited each area for a day or two, people sometimes missed those days and they were not within the screening program, and new cases on registration decreased further. But of course, during this period, we made the headlines of the New York Times. We made the front page of the New York Times in 2018, in December 2018, with the title of Curing Hepatitis C in an Experiment the Size of Egypt, a New Approach Tested in Egypt Could Become the Blueprint for Providing Cutting-Edge Medicines to the Poor. And another one was in The Atlantic, Why Egypt is at the Forefront of Hepatitis C Treatment, and the third one in the Financial Times. So we hit the front pages of the international news. But there are many challenges, of course, with the cost of diagnostics. All diagnostics are imported. The cost was a major part of the costing of the program, and simplifying the monitoring and follow-up strategy could result in major cost savings. Point of care, affordable, of course, HCV RNA testing can further reduce the cost of diagnostic development of local diagnostic tests, will greatly reduce the costs. And in 2018, a breakthrough came with pre-qualification of a point-of-care rapid test by WHO, and indeed a presidential initiative to mass screen the adult population at that time, which was around 48 million above the age of 18 years, by the president. That was full advocacy, not only by the government, but by the president, who recognized that we have a major public health threat. He saw the numbers, He saw all the modeling and cost-effective analysis studies that we've done, looking at the early treatment versus late treatment, and the social impact and the stigma impact and the impact on families and jobs lost. I think that was really a huge undertaking for a country with limited resources. So we adopted cure as prevention of hepatitis C, and not only cure as prevention, but also prevention of complications. You've heard from Professor Quinn early that Egypt also had hepatocellular carcinoma on the rise because of the burden of liver disease, cirrhosis, and advanced liver disease because mainly of hepatitis C. So the target of our campaign was elimination of Hep C 2020 instead of 2030. And we added also an integrated mapping of the non-communicable diseases for all those above 18 years. So the services during the campaign were awareness, HCV testing by a rapid diagnostic test, which was a point-of-care test that gives you the results within a maximum 20 minutes, measuring the blood glucose, blood pressure measurement, and measurement of the body mass index. And we had teams in those sites, a physician, a nurse, and a data entry clerk. Every site had their own tablets and their own registration hub where they could register. Every single person who was screened and tested immediately on the system, and that collected directly on the central database and the central network. And those were the types of screening sites. The majority were primary healthcare facilities, more than 4,000 units shared in the campaign out of around 5,300 primary healthcare facility units in Egypt. 7% were in hospitals, 382 general, central, or university hospitals shared in the campaign. 2% mobile units. We had 135 mobile clinics. And even people could call the hotline number and ask for the mobile clinic to go to their homes to get tested. We had youth centers, 215 youth centers, 10% other facilities, mobile teams located in clubs, big squares, mosques, churches, in government buildings, etc. And those were the phases of the campaign. We started the campaign in 3 phases. Each phase was between 2 to 3 months, from preparation 2 months to reporting 2 months and data analysis. And in the middle, we had 7 months with the 3 phases. And each phase had several governorates or states included, with a target population of between 17 to 23 million. And the number of medical teams working ranged between almost 6,000 to 8,000 medical teams in those phases. We had also external audit from an NGO and from WHO, and for patient evaluation and treatment. And you can read the details of this campaign in the New England Journal of Medicine article that we've published in 2020. So those are the screening sites. The sites were working 9 to 9 p.m., 9 a.m. to 9 p.m., 7 days a week, 30 days a month, and over 20,000 medical teams were within this working in the campaign. If we look at the data registration system, that's how it looked like. It was active. We could see immediately how many were tested and how many were positive, and the numbers of those who were tested and how many were negative. And we also could see on our website immediately from the central office how many were obese or overweight or morbidly obese, how many had hypertension on the first measurement or had diabetes. The site was operational end of September once we started our screening campaign, and the screening campaign in each phase had all the types of states, whether rural, urban, frontier governorates. We had training on the use of the rapid test. We had a trainer from South Africa on the use of the rapid test from the company SD Bioline, which was pre-qualified by WHO before its use. And then we had all those communication material and awareness materials distributed in all sites, and all the healthcare providers were trained and educated on the awareness material to be able to educate the patients and the public in those sites. We also had some IT solutions and applications. We utilized the National Elections Commission database to identify those eligible for testing. We linked them to the National Committee for Viral Hepatitis website to refer the patients immediately who test positive to the treatment centers. We had a website of stophcv.egypt. Of course, it was active during the campaign only. The hotline is still active until the moment, and anybody could call the hotline for information. Awareness messages were also sent by text, short messages on the phones of every single person in Egypt to understand where the survey was conducted, to know the sites and where are the closest sites to their home to go and get tested. And this is the flow chart of how we started. This is the person gets into the healthcare facility. In the reception, they give their national ID, and then they search for the ID on the database, and then they would know, because we cleaned up the data systems from those who received treatment and were cured, and then they would look at whether they are targeted or not. If they are targeted, they go for HCV testing. If they're not targeted, they go directly for the blood glucose and blood pressure and BMI measurement. And then they have their own registration card where all the information and data is registered. And if they are positive, they're directly being referred to the treatment centers. Those are all the stakeholders who were working with us in the campaign. It's literally all ministries, including the Ministry of Defense, which was really important in protecting the sites and protecting the whole campaign, and the Ministry of Interior as well, which was protecting also the sites and helping us with the logistics on the ground and the screening and the organization within the centers. And we had some catalytic funding from the World Bank. We had, this was the NGO, it's called Hail Egypt. It's a very official trust fund and NGO. And then we had the WHO auditing the whole program. I'm going to give you just an example of the screening, the number of screening points in the first phase with almost 6,000 screening teams, and those were the mobile units and how they looked like, and those were some of the fixed units that we had. And we even went to the remotest, the farthest place in the desert, and those were the official vests worn by all those working and team members in the 100 million Healthy Lives campaign. And the terminology came from the fact that at that time we were 100 million, the population was 100 million, so that's why it was called the 100 Million Healthy Lives campaign, and that's the logo of the campaign. These are the cards where registration is given, and they're given to the public, including the hotline number, an appointment for further evaluation and referral to care if tested positive, or if they need further evaluation for diabetes, hypertension, or an advice for being overweight and further assessment. Media campaigns all over the country. We had billboards, TV, social media, advertisements on TV. It was everywhere. It was the whole country actually was mobilized. And those are also media campaigns, Instagram, social media. The young people, as you can see, were an integral part of these campaigns. And we've done a lot of awareness activities. These are some of the activities done. This is a screening on the top right of students in universities, military recruits and police clubs and prisoners. That's in churches. Here we had also some of the units and some also of the screening and the awareness campaigns in the villages with also women leaders in villages. We had some of the events also organized by the young people, like Alex Runner's events, that's in Alexandria, with also telling them, please share and be part of the campaign, be proactive, go and test yourself, and please try and be healthy. That's the healthcare professionals team among students and young people. And the result was more than 14,000 people were screened. That was on one day in Alexandria after the prayers on a Friday and after the running event. Those are the distribution of the centers. As you can see, it covers all over Egypt. And depending on the number of populations, of course, these are the desert part of Egypt. It's not highly populous. There's a very small population in these areas, and that's why we have single centers in those areas. But of course, in the Delta region where it's overpopulous, and also we have a high prevalence rate in the Delta region because of the old days of schistosoma therapy and injections and injection safety issues. But it's this is the most highly prevalent HCV in this area. So I had in total 172 centers and 123 dispensing clinics that dispense treatment. And if we look at the prevalence here, we'll find that Cairo, because of course it has a 20 million population, the prevalence was around 4% infected, but the highest prevalence was around 9% in the governance in the Delta region, where always we had a high prevalence rate, and in some areas also in the Upper Egypt, which is the lowermost part of Egypt. And of course, for gender distribution, men had a higher prevalence rate than women. But we also include marginalized populations. One of the nice things about our program is that what's complete equity, or even those who injected drugs were tested within the programs. Nobody was asked about the risk factors at all. The people were tested equally in all centers. And even we had a special program for prisoners, testing a lot of prisoners, and everybody actually now is being tested and treated and cured. Migrants, Egypt has integrated within its population 16 million migrants and refugees. We don't have refugees like other countries, but people become integrated within the community and part of the network of the community. But we also tested those who were registered at the United Nations High Commission for Refugees for hepatitis C, and they were also treated for free. It's to be noted that everything was completely state-sponsored. So the test, the referral, the treatment, everything was supported by the state, and the patients did not pay for any test that they have undertaken during their whole journey. But let's look at our pediatric program, which is very unique. It's the only program in the world. If you look at this study, the global modeling that WHO is adopting right now, I've done this study in collaboration with Center for Disease Analysis, Homi Rezavi and his team, who have done all the modeling studies for the global burden disease. And we estimated around 3.2 million children infected globally. But you'll be surprised to know that in Africa alone, there are 1 million of those children who are viremic. So the numbers are not very low. And if we're planning to eliminate hepatitis by 2030, we should include children. And if we look at this huge number of 2.3 billion children below 18 years, making up 24% of the world's population in 2019, that was a huge advocacy piece, followed by a couple of advocacy pieces that we published for both Hep B and C in the Lancet Gastro and Hepatology in collaboration with WHO. And based on those advocacy pieces and others that I'm going to show you at research level, we managed to have a full chapter for treatment of hepatitis C for children above the age of 3 years. And that was a huge achievement. Of course, very few countries have programs that includes hepatitis for children. On top of those is Egypt. And Egypt is the only country that was proactive in screening children. And we managed to convince the president to include children. Looking at the 100 million Healthy Lives Initiative for adults, we managed to test in 7 months almost 50 million of the population, and our target population was 48, and we screened almost 50. And we had around 2.2 million who were antibody positive for C. For children, we had a similar parallel program, but it was a school screening program. But of course, the school screening program had different preparations. I had a special protocol for children. I had to train the physicians on the protocol because they were all general pediatricians. And then we had also a special website operational for the school screening program. As you can see here, similar to the adult program, they had to provide their birth certificate, which had their national ID number. And then the targeted high school students were 12 million, and we achieved more than this number right now because we had more students coming in for the above 12s over the past 4 years. And we are continuing the school screening program testing on a yearly basis. And those are the number of teams and physicians trained. And we had with us working as stakeholders, the Ministry of Education, the National Council for Childhood and Motherhood, the Ministry of Information and Technology as well, the Health Insurance Organization, and of course, the representatives from WHO and the National Committee for Viral Hepatitis. I've been the clinic director of this program and the initiator and founder of this program for many years now. And of course, we had a lot of awareness to do and community engagement. Of course, for ethical considerations, participation was voluntary, complete privacy and confidentiality to avoid stigma. So no teachers or colleagues or peers were allowed inside the room when the child was tested. And the test positivity was only informed to the parents, and they were given an appointment at one of the centers to be able to start and get the further testing and treatment. And the whole campaign plan and consent form was approved by the National Council for Childhood and Motherhood. And we had some challenges of delayed receipt of consents, data entry problems, adolescents registered, but they don't attend schools. Some of the young females got married early and they were getting homeschooling, manual recording of some cases, network connections problems in remote places, multiple stakeholders, disrupting school schedule, and we had to agree with the school on the right schedule so it won't disrupt the exams or the schedule. 15% of those scheduled for confirmation testing didn't turn up, but we contacted them, and some of them we managed to get them into the university hospital centers I'm going to tell you about now. Cultural barriers in some villages rejecting to treat females in public hospitals, and those were the ones we targeted for our NGO work. Difficulty in contacting the parents and capturing those with high-risk behavior and in juvenile prisons. And after many publications coming from Egypt, mainly on the use of DAAs in children with hepatitis C, and unique experiences with using the generic drugs, especially the sofdeclatazvir, we had it finally in the guidelines of the WHO. I've conducted a PK study for the adolescents with the sofdeclatazvir, and based on this study and on these data, we've done a collaborative modeling study with the WHO that was published in the Pediatric Journal of Infectious Disease, and modeling also the younger age groups. And I'm currently doing the validation study for down to 14 kilograms with SOFDAC. And why SOFDAC? Because SOFDAC is the most available in resource-limited settings. It is the most affordable combination and most accessible for the areas with the highest prevalence of HCV, both in adults and in children. So it is the low-cost daclatazvir formulations, and there is a special company in Egypt that's producing the special formulation right now, and we're looking forward to finishing and finalizing the study at my center and validating and registering the formulation. We've done also studies to validate and look at linkage to care for pregnant women and testing pregnant women during pregnancy and following up the infants after screening, and immediately linking mothers to care and to treatment. And that's one of the micro-elimination projects that I've conducted. So what are the lessons learned for adolescents and children and maybe women in childbearing age? How to overcome service delivery issues in adolescents, including consents, confidentiality, access to diagnosis and treatment. Schools, we included both public and private schools and all types of schools. It could be a platform for children and adolescents offering awareness and HCV testing in populations with high prevalence rates. Testing and treatment of children and adolescents should be part of national programs offering access to diagnosis and care to adult populations to achieve elimination. Of course, we couldn't have done it without the verification workforce and auditing mission of the WHO, some technical guidance and community awareness, and that ended up in just publishing this year the WHO verification of Egypt's hepatitis C, a non-communicable disease mass screening campaign, the 100 Million Healthy Lives campaign, that will eventually give Egypt the elimination certificate. So the achievements of the screening, almost above 60 million people, a prevalence of 4.5% for those above 18, 0.4% for the less than 17 or less than 18. However, we had high prevalence rates in some of the governorates that we focused on, up to 1%, 0.2% for the 12 to 14s, 0.7% in the migrants, and in special population groups like prisoners, it was 14%. And that's a target group. We're still working on them because those, when they go out, they're going to be, again, a source of the infection for the families. And I'm going just quickly to give you highlights on the provider's critical role in these campaigns and how we can really make a difference. And you as students also, not only as faculty, can make a huge difference. Advocacy among physicians, students, unions, student unions, we worked with so many of them, the FEMSA, civil society, key opinion leaders, awareness among patients, families, care providers, students, public media, removal of stigma and discrimination, and access to diagnosis and medicine. We made the difference. Our university campaign, 2009 actually, it continued even after the revolution to 2013 and 2014. We had information booths and camps and sports events and seminars. I reached out to more than 100,000 students in 19 universities. After the campaign, I had almost 6,000 volunteers working with me all over Egypt. I had two famous actors, an actor and actress, an actress called Yusra, very famous in Egypt, an actor, a young actor at that time, Amr Waked. You might have seen him in some movies in Hollywood. He participated in some of them. And also we had multiple private-public partnership where we were provided with funds to provide vaccination for free for hepatitis B. And we vaccinated 30,000 students from medical schools and nursing schools. And the campaign also made all university presidents to advocate for obligatory vaccination of those in medical schools and nursing schools. We had another campaign later on for hepatitis C awareness in my university, education, empowerment, and screening for students, as well as the employees and the healthcare providers. And we detected all those who were detected were treated in our center at Ain Shams University. But not only that, but also the healthcare providers have driven community-based educate, test, and treat approach in Egypt. And this is a fantastic example of Professor Gamal Chiha with his NGO going to villages, doing community mobilization and campaigns, education and fundraising for public. And this was published in the Lancet Gastropathology as well. And my project with the Egyptian Liver Care Society for the C-Free Child Project, that was phase 4 with the DAAs. We finished the first 3 phases with interferon, and it had the treatment part, the training part, the awareness part, and the auditing and regular visit. And we have equipped more than 1 center all over Egypt in university hospitals, fully equipped and trained physicians to deal with children. And this is currently being finalized and under publication. And those are some of the interactive sessions for parents and children that we've done. And some of the distribution of prevention and personal care items, prevention material, distributing them to children. And during the COVID-19, teaching children and adolescents how to get on the website and explain how to access the training website and what to do, and doing all the precautions for the blood draws and, of course, the temperature check. But of course, I'll go back to what we've done for over the years. Me and my colleagues in the National Committee, we had tens and tens and tens of monthly articles about hepatitis C in Egypt. We were on TV on many occasions, in the media, on the radio. We had social media, on Instagram. but we're still not there. If you want to really eliminate hepatitis C, we have to hit the front lines of all those international journals, like the HIV AIDS has done for many, many years and still are, and others like Ebola, hepatitis C only once many years ago on the Newsweek. So finally, how we did it: screening over 60 million people, catalytic investment from the World Bank. And with the catalytic investment, we managed to do the huge campaign, but that's the result, that we are averting by 2030. Before initially we were planning to eliminate by 2030, but eliminating by 2020 averted more than 250,000 HCV-related deaths by 2030. And the incremental cost effectiveness ratio for the program was calculated at around $1,000 per DALY averted. So I think that was worth it. So for the Kingdom framework, we had 3 streams: a problem stream, a policy stream, and a politics stream. I'm going to focus on this. Maybe I explained this in detail, what we had, the unsafe injections, the burden of disease, etc., and what we've done in the policy stream until the screening. But you have not learned about this, that during our program, we had 2 uprisings and revolutions, one in 2011 and one in 2013. And the country was in total chaos. But you will be surprised that our centers were not touched, despite that many centers were burned down and were sabotaged, and it was total chaos in the country. But those centers, because they were giving very unique services, and every single house in Egypt had somebody who was infected with hepatitis C. And we managed to get through with a very consistent program that was not interrupted for a single day. And that, I think, is one of our major achievements. So finally, we need to have a continuous delivery system, sustainability of awareness, testing, treatment, follow-up, continuous stakeholders engagement and advocacy, and of course, engagement of the civil society community and the media, and of course, the students. And our efforts were commended by the Director General of the WHO in August 2019. And of course, our key successes were a proper planning and collection of data and analysis and modeling, and that's where research comes. And a lot of innovations in implementation, government commitment, empowerment of the public and the media was key, engagement of stakeholders and accountability and monitoring framework for surveillance, and leveraging on previous experiences and integration in existing infrastructure when possible to succeed. So these are the summary of the findings: identifying and facing the problem, huge social and societal pressure for government funding, and that's our role as physicians, as students, as people and community, political will and support, setting up infrastructure for mass treatment and mass purchase prices, fully reimbursed or subsidized screening and treatment, simplifying screening policies and evaluation. That's available now. All WHO guidelines are simplifying and monitoring and evaluation. And finally, I would like to thank all the members of National Committee for Viral Hepatitis and executive directors and all the stakeholders and partners and patients and their families and everybody who contributed to the program, pharmacists, nurses, everybody. Thank you very much.
Professor El-Saadi, that was so inspiring. It is global health in action. And we couldn't have asked for a better example of taking it from the very beginning of the discovery of HCV all the way to what you have accomplished, moving towards elimination in a country that had the highest level of infection reported. It's truly inspiring. It's transformative. I even wrote down, this is a lesson in implementation science. We talk about implementation science, but it's more than that. It's policy implementation. It's many, many other aspects of how to address a particular disease, how to control it, and how to move towards elimination. Fantastic presentation. I want to open it up to any comments or questions that people might want to have. I've looked at the Q&A, but you've overwhelmed us. It looks like many have already been addressed in your presentation. If anyone has any questions, feel free to unmute and ask away, or raise your hand.
I think there is one comment from Dave.
Yeah.
I believe securing political support came from the pressure coming from the community, from empowerment of the public, from media, from physicians, organizations. I think you need to all get together, and have one voice instead of, not working in silos, because I believe that's what's happening in most of the countries right now. Everybody wants to say that I'm doing this, I'm doing that. It's not like this. I think we need to all work together with the same voice, with the same message exactly, and the same consensus that this is what should happen. And once people have a voice, and I think in Egypt we learned that we do have a voice with 2 uprisings that we've witnessed in the last few years. I think people learned, and the young people in particular knew that they have a voice. And if it starts with the students, that would be really fantastic, because they can make a huge shift in the community and awareness among their families, their friends, their neighbors. They can do this. They can move and mobilize the whole country, believe it or not. The young people can do this on social media. They can embarrass the government on social media. And they are doing this all the time. Why not now? Why not for hepatitis C? Why not talk to the key media people and start and hammer the politicians about the importance? And I know in the US you're having an opiate problem, and it's rising, it's on the rise, and more hep C is being transmitted to children, more hep C is in the women and childbearing age, and we're having more mother-to-child transmission. So what are they waiting for? It's a curable disease, and they can indeed talk to the companies to provide the drugs at a much, much lower price.
Manal, I'll just give you an example. We did do a study on HCV in our emergency department. We do this periodically just to see, have we made a difference? Is there a change? And if anything, the rate of HCV is somewhat increased in the Baltimore population, as we've seen in at least visiting our emergency room. We screened 7,500 people, and just to give you some numbers, 12.5% of those people have HCV antibody, and 5.2%, 5% were RNA positive. The vast majority of those are unaware that they're HCV positive, and we don't have really a routine countrywide or community-wide screening program for HCV like you have implemented there in Egypt. I'm sure that's something that has frustrated people like Dave Thomas, who's still online, that it just hasn't gotten the recognition it so deserves. And it's why we wanted to hear what you had to say about how you did it in Egypt. I wish we could do the same, and we have to strive to do the same. I'm going to quote you and Harvey Alter. Harvey Alter said, one lecture seminar from Egypt about the lessons there are worth over 1,000 different seminars or lectures. And you have really proven that. I've learned so much from you today, and I can't thank you enough for taking the time out of your evening to really be with us. Does anyone else want to add in? Dave's shy, he probably isn't going to unmute, but if you could, you're allowed to.
I mean, sure. Manal, thank you so much. Now using my voice instead of my typing. That was spectacular, and congratulations to you and your coworkers. It's really an amazing and breathtaking accomplishment. One of the other differences, besides most parts of the world don't have the political support, in the United States, we also have a good deal of indifference, if at best, and probably more aptly distrust of our public health system, our government, and that sort of thing. Did you experience villages or regions of the country where there was where they just didn't trust you and they didn't think that you had their interest in mind and that sort of thing?
Yeah, that was happening initially. But I think because we were just telling the people really the truth. Every month we were announcing the numbers treated, what exactly we were doing. Everything was announced regularly on TV and in the media. And then they started seeing their relatives and other members of the family going to those places and getting a cure. At the time, we were struggling more during the interferon phase, because of course, you know that interferon was not the best drug of all. And there were lots of quacks at that time giving people unnecessary drugs, or drugs that are not approved, or herbal medicines that might be hepatotoxic, or even other things like the pigeon. That was something that they were telling people: a pigeon sleeps on your liver. If this pigeon dies, then you're cured of hepatitis. There were lots and lots of myths in the community and in rural areas and villages. But I think the awareness, and I believe that the awareness when it came from the young people to their families made a huge difference. And that's why I'm happy that students are attending today. I've been all around Egypt teaching students in universities and the young people awareness about hepatitis, and that made a huge shift, because I was telling them, you are our messenger to your families and neighbors and villages. And in fact, I have some students who went positively to ask the whole village to get tested and screened, and they did manage to do this. They listened to their children. They won't listen to us. They will listen to the young people. They will listen to their families. They will listen to the students in the families, the educated ones in their families. So please, if you have any student organizations, I'm happy to talk to them. I'm happy to work with them on creating a sort of stir in the community and doing some work of empowerment. And that really was really fantastic. It was all over the country. It was covered by the media. And they can do a lot of social media work that would astonish you and stun you, things that you can't do, physicians cannot do.
Thank you.
I think that's absolutely so true. Getting that type of activism, advocacy, it's what started with HIV. HIV was a good example where we did get a lot of advocacy, mostly from those affected by the disease, our quote, ACT UP and other types. And it finally rose to the government. They realized what a problem they had and they moved forward. HIV still remains a problem in our country as it does elsewhere. But Hep C just hasn't taken the same kind of route. We need more activism. And you said yourself that people in Egypt had family members with hepatitis C. It struck home the same way that it did in many ways with HIV, but it hasn't risen to the level that you were able to bring it to in Egypt. And I envy that you've been able to do that. We've had a few people, Francis Collins for one, who seems to be interested in this, but we need a bigger movement to really bring recognition of the problem to the populace and to move the government. But as Dave said, right now, the government and many of the people have a lot of mistrust in the public health system on the heels of the COVID pandemic and what transpired. So we have our task before us, and I hope we've learned lessons from you in what you were able to accomplish. My sincere congratulations and thanks for really sharing everything with us today. As I said before, I learned so much about HCV control, treatment, and what you've been able to accomplish on a countrywide level. Not seeing anything quite like this with other diseases. You really have started a movement, and I hope we can try and replicate that, not just for HCV, but other diseases as well.
Yeah.
Yeah. Any other comments from the group? We are over time. That's traditional with me. I tend to run over. But people are writing in the chat and thanking you. I know the students that were online learned so much from you. We will stay in touch because I also see for the next consortium of universities for global health, you would be a perfect role model for other people in that particular group. That is a consortium of about 180 universities now that have grouped together to focus on global health issues. And I think what you've been able to accomplish would be a perfect example, learning example for those universities. So we'll stay in touch, Manal, and it's been a pleasure meeting you and having you take the time.
Thank you.
It really was wonderful. Thank you.
Pleasure is all mine. No, thank you. Thank you so much. Thank you so much for your kind invitation. It was really a pleasure.
It's truly our honor and our pleasure to have you. Thanks.